Here I'm going to discuss vascular diseases, starting with atherosclerosis and then moving on to arterial lobe sclerosis and then finally discussing the Monckeberg disorder. Now here starting with the atherosclerosis, this is a pathological process that is caused by the thickening of the tunica intima with fibrous plaques and atheromas, as a consequence of which it will cause diseases of the coronary, cerebral, as well as the peripheral arteries. So here is a structure of a vessel, where you can see that the inner layer is the tunica intima that is made of the endothelial cells, and then with the atherosclerosis it's the tunica intima that has been thickened. The medial layer is tunica media that is made of a concentric smooth muscles which is required for the constriction of the vessels, and so tunica media is actually thicker in arteries compared to veins. And then finally the outermost layer is tunica adventitia, which is made of a longitudinal fibers, and so this layer is thicker in veins compared to the arteries. Now going back to atherosclerosis, this condition is initiated by endothelial damage or inflammation, which contributes to the endothelial damage. And risk factors to endothelial damage, for instance, include hypertension or high blood pressure, dyslipidemia, as well as tobacco smoking. And so, as I just discussed earlier, inflammation is also another factor that will attribute to the endothelial damage. And one important factor that induces inflammation is oxidized LDL, as a consequence of which elevated lipids as well as smoking, which attributes to the oxidization of LDL, can cause endothelial damage. And so this oxidized LDL, once it's being consumed by the macrophages, it will make the macrophages to release cytokines that induces inflammation. And so the first lesion of the atherosclerosis is fatty streaks, which causes focal thickening of the tunica intima, and then there is accumulation of foam cells, which are the same as macrophages that have consumed lipids. So here we have the macrophages that have consumed lipids and are referred to as foam cells. And now foam cells will release growth factor that would cause further accumulation of smooth muscles. And then there would also be deposition of extracellular matrix, which will cause further thickening of the tunica intima layer. And then the lesions can now become more advanced, forming a fibrous cap atheroma which is covering the lipid core. So this type of atheroma is caused by the accumulation of connective tissue with increased number of smooth muscles. So here now we have more smooth muscles as well as the increased number of lipid with a deeper extracellular lipid core that is being deposited here inside the atheroma. And then the outer layer is being covered by a fibrofatty layer. And then finally the lesions can become more advanced, where they would be supplied by microvessels, and then they can cause complicated plaques if there is a rupture, where the plaque can go to different vessels and cause, for instance, strokes or heart attacks. So the complications that can arise from atherosclerosis include the abdominal aortic aneurysm. So atherosclerosis is a risk factor to the development of abdominal aortic aneurysm. It can also cause leg claudication due to the occlusion of the peripheral vessels, cause heart attack, and then finally cause stroke. So the arteries that are most commonly affected by the atherosclerosis include the abdominal aortic artery, and then after that it would be the coronary artery, popliteal artery, and then finally the internal carotid artery. So here now you can see that the accumulation of atherosclerosis in abdominal aorta can cause abdominal aortic aneurysm. In the coronary artery, it will cause heart attack. In the popliteal artery, it can cause leg claudication. And then finally, in the internal carotid artery, it can cause transient ischemic attacks or stroke. As for the risk factor to the atherosclerosis, there could be two types. One is modifiable risk factors, which means that the patient can help reduce these risk factors. For instance, dyslipidemia, the patient can modify the diet to help lower levels of LDL. Or hypertension, if the patient lose weight and start taking less salts, quit smoking, and then control diabetes, then there is a better control of hypertension, and so on. And then there are non-modifiable risk factors, like for instance age. As the age increases, there is increased risk of atherosclerosis. And then the atherosclerosis is more common in males, and then of course genetics contribute contribute to the development also of atherosclerosis. Now, discussing the modifiable risk factors in a little more details. So dyslipidemia, where there is high level of LDL and low level of HDL, attributes to the development of atherosclerosis. So LDL is bad cholesterol because it will distribute the cholesterol from the liver to the peripheral tissues. And so by doing this, there would be now increased risk of the atherosclerosis of the blood vessels. HDL, on the other hand, is good cholesterol because it will collect cholesterol from peripheral tissues and take it to the liver. So reverse of what LDL does. Now, once there is an oxidized LDL, then there would be increased inflammation, as a consequence of which it can cause damage to the endothelial layer and start the process of atherosclerosis. The next risk factor is hypertension, and the way it actually causes damage to the endothelial layer is that it will disrupt the repair process by increasing the arterial wall pressure. Smoking, as we just discussed earlier, one mechanism that it can cause endothelial damage is by causing oxidized LDL, which now can cause inflammation, and then that attributes to the endothelial damage. And then finally, we have diabetes, which can cause increased level of oxidized LDL. It can cause inflammation, and then it can also attribute to dyslipidemia. Alright, now moving on to arteriolosclerosis, where there are two types. There is a hyaline type and hyperplastic type of arteriolosclerosis. So with the hyaline type, which is associated with diabetes mellitus and essential hypertension, this type of arteriolosclerosis is caused by excessive extracellular matrix production by the smooth muscle cells, where there would be hyaline deposition. So here is an example of hyaline arteriolosclerosis, where you can see that there is this hyaline layer that is inside the vessel that causes vessel narrowing. And then the other condition is the hyperplastic arteriolosclerosis, which is caused by malignant hypertension, where there is blood pressure of higher than 180 over 120 millimeter mercury. And so malignant hypertension will cause thickening of the smooth muscles as well as duplication of the basement membrane, and then in addition there would be fibrinoid necrosis inside the tunica intima and media that causes narrowing of the blood vessels. So here with the hyperplastic, also known as onion skinning arteriolosclerosis, you can see that there is a thickened smooth muscle layer. In addition, there is duplicated basement membrane, and then there is also fibrinoid necrosis in the arterial intima and media. Now, in terms of the treatment options that are available for patients that have diabetes, what you will have to provide them to protect against the harmful effect of diabetes is blood pressure medications like angiotensin converting enzyme inhibitors or angiotensin receptor blockers. Example of which, for instance, include lisinopril as an ACE inhibitor or losartan as an ARBs. And how these medications work is that they would decrease the perfusion of the renal vessels. So what happens with the diabetes is that there is glomerular hypertension and hyperfiltration, as a consequence of which it will cause diabetic mediated nephropathy. So here, if we have the afferent arteriole, where the vessels are going in and then go into the glomeruli, and then here we have the efferent arteriole that comes out. And so here with diabetes, there is too much hyperfiltration, which will damage kidneys. And so one way to protect kidneys from the hyperfiltration caused by the diabetes is to lower the blood pressure by ACE inhibitors and ARBs. And how these medications work is that they would cause dilation of the efferent arteriole, as a consequence of which now there would be decreased perfusion of the renal vessels. And so let me discuss that in a little more detail. So here, prostaglandin will cause dilation of the afferent artery. And so if afferent artery dilates, now there would be increased flow into kidneys. On the other hand, angiotensin acts on the efferent arteriole to cause constriction of this vessel. as a consequence of which, by constricting the vessels, again, angiotensin will increase the renal perfusion. And this is due to the fact that now there is more pressure buildup on the glomeruli. And so how these medications work is that they block the function of angiotensin, so there won't be any more constriction of this vessel. So now this vessel, due to the angiotensin receptor blockers, would be dilated. And so if it's dilated, less fluids will be filtered into the renal vessels and more will be get out into the efferent arteriole. So therefore, by the application of the ACE inhibitors and ARBs, there would be now decreased hyperfiltration of the renal vessels due to the dilation of the efferent arteriole. And so this is one mechanism that the diabetic nephropathy can be prevented by antihypertensive medications. Alternatively, with malignant hypertension, since there is now thickening of the smooth muscles as well as the fibrinoid necrosis, it will cause too much narrowing of the blood vessels, as a consequence of which there is so little supply of the blood to the renal vessels. And so now that's one mechanism through which malignant hypertension can cause kidney injury. So in order to prevent kidney injury in these patients, we will have to increase the blood flow. And one way it can be done is via the medications phenol-dopam, which is a dopamine D1 agonist that will increase renal perfusion by relaxing the renal arteries. So let me quickly summarize what I just discussed here. So with the diabetes, which can cause the hyaline arteriolosclerosis, we will have to provide these patients with the ACE inhibitors or ARBs to help decrease the renal perfusion, and so therefore prevent diabetes-mediated kidney damage. On the other hand, with the malignant hypertension, there is too little blood flow into the renal vessels, and so therefore we must prevent kidney damage by providing phenol-dopam, which is a D1 receptor agonist that will dilate the renal arteries and thus increase renal perfusion. Alright, now moving on to the Monckeberg arteriolosclerosis. So this is actually an asymptomatic condition that is caused by the calcification of the tunica media layer. And so this is usually affecting the medium-sized arteries, like for instance ulnar and radial arteries. So here I have the histology of the vessels, where you can see that there is a tunica intima layer right here. We have the tunica adventitia on the top, and then finally we have the tunica media. And then you can see that inside the tunica media we have this huge calcification that is going on. And again, this condition is asymptomatic, and then on the x-ray, since there is too much calcification of the vessels, you would actually be able to observe the vessels. So here is an example of the vessels that you can be able to observe on the x-ray due to the calcification of the tunica media. And that concludes our discussion of the vascular diseases.